Capstone Review, Part 3. We're going to move on now to the microscopic exam of the urine, and this is where we're identifying insoluble substances from the blood, kidney, lower urogenital tract, and external contaminants. So we need to be able to identify things that perhaps shouldn't be there, things that are there that might be contaminants, things that are present in the urine that may look like clinically significant things but really aren't. The standard rules for a microscopic exam are examine fresh or properly preserved urine. About 10 to 12 milliliters needs to be centrifuged, and then you pour it off, leaving 0.5 to 1.0 milliliters of sediment. You reconstitute that. You report WBCs, white blood cells, and red blood cells on high power. You report CAS low power, and all formed elements must be identified and quantified. Well, that's going to depend on the laboratory you work in, and every laboratory, trust me, is going to have different protocol for quantifying things. Certainly, you're going to count and give a number, or at the very least, a range of number for white blood cells, red blood cells, and you're just going to report, as far as CAS, you're not really going to count those. Usually, you don't anyway. It's going to be 1 plus, 2 plus, or perhaps it could be a range of numbers. Again, it depends on the laboratory. Basically, when it comes to a microscopic exam of the urine, you just report what you see and let the physician decide how clinically significant it is or not. So normal urine can have 0 to 2 red blood cells per high power field, 0 to 5 white blood cells, 0 to 2 hyaline casts, possibly could have several epithelial cells, especially if it's from a woman, can have some crystals, and that can be normal, and there certainly can be mucus present in a normal urine. So these things should not be alarming. Again, you do report what you see, and in the absence of any other things being abnormal, again, this should not be alarming to anyone. Red blood cells. The number of cells counted relate to the extent of renal damage or glomerular membrane damage or urogenital tract damage. So wherever the damage is occurring, the number of cells that are present relate to the extent of that damage. Things that can cause this: infections, toxins, cancer, circulatory problems, renal calculus, menstrual cycle contamination, trauma, and exercise can cause a person to have small to perhaps moderate amounts of blood in their urine. Normal urine, red blood cells will appear as colorless discs. In concentrated urine, the red blood cells are going to look crenated. And in dilute urine, if you see the cells at all, because they could have lysed, they're either going to be ghost cells or swollen. They're going to look swollen, taking on too much water. It's important not to confuse red blood cells with yeast. One way to differentiate if you're confused or can't really tell is to add a drop of dilute acetic acid or glacial acetic acid to the slide. This is going to lyse the red blood cells and leave the yeast cells intact. Oil droplets and white cells will also stay intact. It takes a lot of practice to get to know these cells, and when you're just starting out, and the experience you gain in the student laboratory isn't even close to what, pretty much where you need to be for the real world, but hopefully you gained a lot of experience looking at cellular components in your practicum. This is just an image of red blood cells. Obviously, they look stained here, but there weren't very many great pictures of blood cells in urine. You really have to have the luxury of focusing when it comes to red blood cells in a urine sample. White blood cells are due to pyuria. That's the term for white blood cells in the urine, usually due to bacterial infections, perhaps pyelonephritis, cystitis, prostatitis, or urethritis. Non-bacterial reasons why a person might have white blood cells in their urine include glomerulonephritis, lupus, and some tumors. Glitter cells, you can find these in dilute alkaline urine, and what you're seeing is they look like they're kind of green, and that's due to the Brownian movement of the granules inside the cells. Eosinophils you might see in urine. Oftentimes you're not going to be able to differentiate them unless you're staining the urine sediment. However, that can be drug-induced nephritis or possibly renal transplant rejection. Here's an image of some white blood cells in urine, and remember, between white cells and red cells, these are going to look kind of granular due to the nuclei and the granular composition of white blood cells. Epithelial cells, there's many different types that we can find in the urine. Squamous or squamous, depending on where you went to school. An excess number of squamous epithelial cells indicate perhaps contamination, especially if the sample came from a female. Clue cells, these are very heavily infected epithelial cells that have bacteria inside of them. This usually is a vaginal infection. A vaginal infection generally with Gardnerella vaginella. And so it's common to see squamous epithelial cells. It's fairly normal. It's part of the normal sloughing process of the urogenital tract. You're going to see, obviously, a lot more squamous epithelial cells in women than in men. Transitional epithelial cells can indicate renal carcinoma or perhaps a viral infection, or you might see them after catheterization. Renal epithelial cells are probably the most clinically significant. They suggest tubular injury if there are greater than 5 of them per high-power field. Within the renal classification, you have things called bubble cells, which indicates renal tubular necrosis, and oval fat bodies, which suggest nephrotic syndrome. You can also see something called histiocytes in the urine, and they are a type of epithelial cell, and that indicates a lipid storage disease. And these are usually differentiated because they're larger than oval fat bodies. Here are some examples. The upper left here is a squamous epithelial cell. They're usually very large. They have a very small nucleus. Sometimes can look somewhat granular. Either debris is inside them or laying on top of them. Oftentimes you'll find squamous or squamous epithelial cells in sheets, all clumped together there. This slide here is of transitional epithelial cells. They're usually fairly round, and a lot of times you'll see a number of them together as well. These small down here are the renal epithelial cells, and they are smaller than any of the other epithelial cells that you'll see. Some laboratories do not differentiate between renal and transitional epithelial cells. They just call them round epithelial cells. So I'm not going to argue for or against that. You just need to follow your laboratory protocol. Most labs I've ever worked in did differentiate between squamous and renal and transitional, but I have worked in a few that if it was transitional or renal, they didn't really care. They just called them a round epithelial cell. Casts are something that are unique to the kidney, so they are formed within the lumen of the distal convoluted tubule and the collecting duct. So usually they form because of urinary stasis. The major constituent of casts are TAM horsefall protein, and they also contain albumin and immunoglobulins. Lots of different casts to identify. You just need to do your best at differentiating the different types of casts there. Some of them can be normal and some of them very abnormal, so you need to be able to look for these. Remember, they are reported per low power field, so you want to take a look on low power, turn down that light. They like to hide out around the periphery of the cover slip, and turn down that light so you can see them. You need to use your microscope skills and finesse and focus back and forth and to try to find a lot of the casts. Highland casts, some of these images aren't that great, but it gives you a little bit of an idea. Highland casts are probably the most common that we see. 0 to 5 per low power field is they're normal. And you can find these after exercising, in states of dehydration, emotional stress, and in the heat. They are associated with some diseases, so you're going to see hyaline casts in cases of acute glomerulonephritis, pyelonephritis, chronic renal disease, and congestive heart failure. They are colorless usually, and their morphology varies. Usually if there's one, there are more. And once again, they can be normal, but they also have some disease associations. Cellular casts. Red blood cell casts first. They obviously contain red blood cells. These can also be found following very strenuous exercise, marathon runners, that kind of a thing. They are associated with bleeding within the nephron, glomerulonephritis, or damage to renal capillaries. They appear orangish or reddish in color. They contain hemoglobin and intact red blood cells. And you can see by this, it looks like, especially if you had the liberty to focus up and down, you would see that those are red blood cells inside, comprising of that cast. Similarly, we can have white blood cell casts, and obviously they contain white blood cells. They are associated with infection and pyelonephritis and any kind of inflammation within the nephron. They primarily contain neutrophils. They can contain other white blood cells, but usually if you see them, they are containing neutrophils. They are highly associated with pyelonephritis. If you take a look here, you can see that the individual white cells inside here look just like a white blood cell. These are not normal at all under any circumstance. When you see white blood cell casts, there definitely is something going on. There is some kind of disease association. Bacterial casts are not something that you may necessarily see a lot of. They do exist. Associated with pyelonephritis, you would also see white blood cell casts with bacterial casts. They usually appear with bacilli contained within the cast and bound to the surface of it. And you can also find mixed casts containing bacteria and white blood cells. I couldn't really see images of this. I don't think that these are very common. As far as us seeing them, they may be there, but I'm going to guess that most people are just going to call these a finely granular cast and not be able to differentiate and see exactly what's in there to call it a bacterial cast. Epithelial cell casts, in my opinion and in my experience, are, unless it's really obvious, kind of hard to take a look at. A lot of times they can look very much like white blood cell casts, but they are associated with very advanced renal tubular damage, heavy metal, chemical, drug toxicity, viral infections, and allograft rejection. And usually these will contain renal tubular epithelial cells. For those of you that have been out in practicum and have experienced this, sometimes renal tubular epithelial cells can look an awful lot like white blood cells. So you have to be careful here in differentiating those. If you need help, ask a supervisor, ask a coworker, and get a second opinion. Granular casts are resulting from glomerular precipitates. Usually they are a breakdown product of cellular casts or some protein aggregates that exist in the urine. They're often seen with hyaline casts following stress and exercise. So they're granular. We can't determine what's inside the cast. It doesn't look distinct enough to say, well, those are red blood cells or white blood cells or whatever. You're just not sure, and they look grainy. They look granular. So coarse or fine, some laboratories choose to differentiate, well, is it a coarse granular cast or a fine granular cast? Some laboratories I've worked for don't really care. You just report granular cast. The color of them, fine granular casts are usually gray or pale yellow, and coarse granular casts obviously have larger granules, and they can appear to be a little bit darker. Waxy casts are probably the most distinct casts out there. They contain surface protein. Some granules can adhere to the cast matrix, and they are formed from the degeneration of granular casts. They are associated with chronic renal failure and significant urine stasis. So when you see waxy casts, that's not a good sign at all. Definitely need to report those out. They have a very high refractive index. They are colorless to yellow, have a smooth appearance. However, it's very common to see cracks or fissures on the side, and I thought that the image that I have at the top here was a pretty good example. They usually look they don't look as tubular as some of the casts do, especially the hyaline casts. They usually kind of have this square edge, and once again, they look cracked and they look waxy because of that surface protein. Fatty casts are seen with oval fat bodies in disease states that result in lipids showing up in the urine. Nephrotic syndrome, toxic tubular necrosis, and diabetes mellitus are all diseases that you may see fatty casts. These can often be confused with granular casts or maybe even some cellular casts. But they are very highly refractile, and they kind of are yellow-brown in color, and they kind of look like they contain fat droplets. To confirm this, you would want to ID using a Sudan stain, or if you're lucky enough to work in a place that has a polarized scope, you will definitely see the Maltese cross formation that is so significant with any kind of lipids, oval fat bodies, anything like that. So this wasn't a really wonderful image, but obviously I believe this was actually stained by Sudan 3, and so they show up a little bit better than the rest of the sediment in that image. Broad casts are formed in the distal convoluted tubule and the collecting duct due to anuria. So this also has renal failure. They are most commonly granular or waxy casts, but they are bigger. And I've worked for labs that did not differentiate between waxy and broad casts, which technically is not correct because all types of casts can occur in a broad form, and it's just indicating that the kidneys are not working at all. So be wary of that. If you see a very broad cast that is definitely cellular or anything like that, once again, get a supervisor and confirm, but most of the time they're waxy. All right, bacteria is not in normal urine unless it was not a really good collection process, especially from a female. If true bacteria is in the urine in significant amounts, it is indicating both lower and upper urinary tract infections. You do need to be able to distinguish bacteria from amorphous material. You can do this by either Brownian movement or possibly motility. Clearly, if you have very clearly rods or bacilli, that would be a good clue because amorphous material isn't necessarily going to look like that. But you definitely need to be careful with that. Usually if bacteria is present, it's present in enough amounts where it's pretty evident. Yeast. This can cause urinary tract infections, vaginal infections. Individuals who have diabetes mellitus battle this constantly. And immunocompromised individuals will also be very prone to yeast infections. You want to look for budding yeast. Once you see budding, look again. You're probably going to see pseudohyphae and so on and so forth. But sometimes you don't see budding yeast and you don't see pseudohyphae, and you're just thinking to yourself, oh my gosh, those look an awful lot like yeast. I'm just not sure. It could be red blood cells. You want to make sure you get out your glacial acetic acid, add a drop, and see what happens. If yeast truly is there, they will still be there after you add that drop of acetic acid. Parasites, the one that we're looking for is Trichomonas vaginalis. This is the one that if you see it in a urine sample or in a wet mount prep, they're there because they move really fast. They're not moving. You really, truly cannot say that they're there. And, 9 times out of 10, they are going to be moving. They're going to be moving really fast. And you'll be able to see the flagella, especially if you have the luxury to focus up and down. It's hard sometimes on a still photograph like this one. You can kind of see the flagella there, but truly not moving. You really can't say that they're present because they look an awful lot like white blood cells, or at least they can. Other parasites that are possible to see in urine may be pinworm, Enterobius vermicularis, but that would be really awful collection, terrible contamination, obviously, from the region. But with children, you just never know. It's hard to get urine samples from children, so it's possible you could see pinworm eggs. Mostly, I can't imagine, maybe a live worm here and there, but mostly we're looking for Trichomonas vaginalis. Very common to see sperm in urine, especially individuals who just had intercourse or men having nocturnal emissions. These are not really clinically significant except for forensic cases or male infertility. So there is a time and a place for sperm analysis. Just because it's not clinically significant, however, doesn't mean you shouldn't report it. If sperm are there, you should report it there. And the physician, again, can determine how significant this is. My one example that I have in my entire career where sperm were clinically significant to the physician was I worked in a laboratory. It was fairly small but pretty busy. And there was a 14-year-old girl who was pregnant admitted to the OB floor, and she was having very early preterm labor, and they were trying to figure out what was going on, and she was on bed rest. And so I did her urinalysis, and there were sperm present, and so I reported that. And the next thing I know, the physician is calling and saying, we're going to be ordering a urinalysis on her pretty randomly throughout the weekend. And I thought, well, whatever. I didn't ask any questions, but he offered. He says, yes, we've determined the source of her preterm labor is more than likely having sexual intercourse with her boyfriend. And so sure enough, subsequent samples were also showing up sperm, and finally they caught you in the act and ordered the boyfriend to leave the hospital premises. Anyway, I don't know if if she ever had that baby or what happened, but crazy things happen, and that's about the one and only time where the physician was actually ordering urinalysis samples to look for sperm. Okay, mucus is a protein substance produced by the reticuloendothelial cells in the urogenital glands. Mucus is generally not clinically significant at all, but we still report it. They appear as thread-like structures. They have a low refractive index, and you want to make sure you don't confuse mucus with hyaline caps, although it is very common both present in urine. On to crystals. Crystals are formed by the precipitation of urine salts, organic compounds, and medications. The formation of crystals can be altered by temperature, pH, and urine concentration. And pH is very important for determining the crystal types. Once again, they differ in solubility. And all clinically significant crystals appear in either acidic or neutral urine. So the ones that appear in alkaline urine are really not clinically significant. However, guess what? We still do report them. So I've organized our crystals kind of by pH. And so I've listed the different kind of crystals that we would find in acidic urine. So I have them listed here, and we're going to talk about them pretty much individually. Amorphous urates. They're formed from urate salts. They do not have a clinical significance. They're small, yellow-brown. Refrigerated samples will result in a pink pigmented urine, and that's due to the amorphous urates present. They will dissolve at an alkaline pH, or if you heat the urine beyond 60 degrees Celsius. Not clinically significant. Uric acid crystals are seen in gout, chemotherapy, and something called Lesch-Nyhan syndrome. They are yellow to orange-brown, but can be colorless. They are pleomorphic. So, unfortunately, uric acid crystals have all kinds of different shapes. You can see four-sided plates, rhombic plates, wedges, rosettes. You see this shape in this image quite often. And so you definitely need to have an atlas sitting by your side when you're less familiar with some of these crystals. Calcium oxalate are probably the most easily distinguished. They look like an envelope. They are derived from oxalic acid. They are colorless. The dihydrate form is an octahedral envelope. The monohydrate form is a dumbbell or an oval shape. They're associated with renal calculi formation. And also the monohydrate form, cell shape, is seen in children who have ingested ethylene glycol or antifreeze. Bilirubin crystals are not normal. They appear as fine needles or granules that are yellow to brown, and you most often see this in liver disease. And so they kind of look like bundles, but you can see them individually as well. Tyrosine crystals are also abnormal. They're fine, delicate needles found in clumps or rosettes. They are colorless to yellow. They're also associated with severe liver disease and inherited amino acid metabolism diseases. So the way to differentiate these from bilirubin crystals is they're more slender, they're more delicate looking, and even though they can look kind of yellow, it's a different kind of yellow than you would see with the bilirubin. Leucine crystals are also abnormal. These can appear yellow, brown. They kind of look oily. They're spheres with concentric circles and radial striations, so also very distinct looking. They're associated with severe liver disease and also inherited amino acid metabolism diseases. Often they are found with tyrosine crystals. So both of those are abnormal, and if a person has severe liver disease, you would probably see those together. Cysteine are also abnormal, and these are also easily distinguishable because they are colorless and they are shaped in a hexagon. They look like hexagonal plates. You will see these in congenital disorders that inhibit renal tubular reabsorption of cysteine. They are also associated with renal calculi formation. Cholesterol crystals are abnormal. They're clear, flat, rectangular plates, and they have a notch in one or more corners. So these are kind of cool looking and also easily distinguishable from others. They're commonly seen in refrigerated samples and oftentimes accompany fatty casts and oval fat bodies. So you'll definitely want to employ your polarizing microscope here. They are associated with nephrotic syndrome and other disorders that produce lipiduria. Crystals from medications. Ampicillin and sulfonamides will form crystals, and you will see this in the urine. Ampicillin crystals are colorless. They form needles, and they may form bundles. Sulfonamides are colorless to yellow-brown, and that's what's in the image here. They form needles, sheaves of wheat. Some people think they look like sheaves of wheat, or fan formation or rosettes. So you can definitely see a fan formation here. Radiographic dyes can resemble cholesterol crystals. Usually you kind of know if the person just had a radiographic dye test. They correlate with increased specific gravity. On to alkaline urine crystals. Now remember, these are not clinically significant. However, we do report those. So the clinically significant crystals are found in acidic and neutral urine. So I have the alkaline urine crystals listed here, and we'll go through usually as well. Okay, amorphous phosphates. They look like amorphous urates, but they are usually colorless. And if you need to know the difference because perhaps it wasn't a refrigerated sample, check out the pH. Refrigerated samples, they will appear as white sediment, whereas the amorphous urates, remember, appear as a pink sediment. These are soluble in acetic acid, but they will not dissolve with heat. They have absolutely no clinical significance whatsoever. Triple phosphate. These are the colorless 3 to 6-sided prisms that resemble an envelope or a coffin lid. They also do not have a clinical significance, but they may be associated with urinary tract infections. Phosphate are colorless, thin prisms or rectangular plates, no clinical significance, but could be associated with renal calculi. Oftentimes they will form kind of a rosette shape as well. Ammonium biurate are funny looking crystals. They are normal. You don't see them unless you have a very old urine sample. If acetic acid is added, these will convert to uric acid crystals. They will dissolve at 60 degrees Celsius. They're yellow to brown spheres with striations on the surface. They're irregular looking with thorny projections. I think they look kind of angry. They just look like some sort of alien in urine. They don't have any clinical significance, and usually you don't see them unless the sample is old. Calcium carbonate. No clinical significance. I apologize, the image didn't get moved over. They're small, they're colorless, they kind of have a dumbbell shape or a barrel shape. So these are calcium carbonate. Okay, so that rounds out the crystals and the other cellular components of urine that we might see. So now we're going to switch gears a little bit and talk about some special urine screening tests. Actually, we're not going to talk a lot about them because I would like to remind you that only 9% of your Board of Certification exam is urines. So PKU test can be done on urine, tyrosine, alkaptonuria, melanuria, maple syrup urine disease, and argentothenoma things that could be tested for. A lot of times these are 24-hour urine collections, and there are special procedures for collecting the urine and processing the urine prior to sending it out to a reference laboratory. But it's important for these to be detected, especially urines. Obviously, the presence of phenylalanine in the urine is indicating a metabolic disorder, and if not treated or detected and nothing is done about it, it can result in severe mental retardation. And so PKU screening tests are done to prevent this, but not every baby goes to the hospital to be born. And so, you just might run into a baby or a child who needs to be screened. Their urine needs to be screened for this. So this is the one that gives off that mousy odor. To be perfectly honest with you, I don't really know what that means. I don't know what mousy smells like, but all the texts love that buzzword. So just correlate that if you see a question on your boards. So PKU testing, you can test for tyrosine in the urine, and this is also due to inherited or metabolic issues. A lot of times tyrosinemia or excess tyrosine in the system is a lot of times fatal and results in liver and renal diseases. So there is a screening test and a confirmatory test for this. Alkaptonuria is a genetic defect resulting in failure to produce homogentistic acid or homogentistic acid oxidase, and then you get an accumulation of homogentistic acid in your blood and the urine. You will find that the blood turns a brown color, and the condition usually leads to liver disease, cardiac problems, and so on and so forth. Let's see, melanuria, increased melanin in the urine, usually produced from tyrosine. And this is the one where, upon standing at room temperature, the urine will darken. So this is indicating a melanoma, which is not good. And there are screening tests for this as well, the ferric chloride and the sodium nitroprusside test. Maple syrup urine disease, very uncommon, but probably very well known just because of its name and the fact that it has a maple syrup smell. Also the breath and the skin of individuals that have this smell like that. Has to do with altered metabolism of some amino acids, specifically leucine, isoleucine, and valine. If untreated, also can result in severe mental retardation, hypoglycemia, convulsions, so on and so forth. If not detected within the first year, it's usually fatal. And there is a screening test for this as well. Argentaphinoma. This is produced by increased blood serotonin, and the major excretion product of increased serotonin is 5-HIAA, 5-hydroxyindole acetic acid. So I'm sure you've seen this in test lists before, the 5-HIAA, and that's what they're taking a look for. The patient must be on a diet free of bananas, pineapples, and tomatoes, which contain significant amounts of serotonin. So there you have it. This concludes session 3. It's kind of a long one, lots of information, but definitely go through and absolutely be able to identify these cellular images. I'm guessing with not any questions on your board, you'll at least have some kind of image derived from the urine. And so good luck studying, and we have one more review session left. Thank you.